My name is Charles H. Hennekens. I'm the first erythritol professor and senior academic advisor to the dean at the Charles E. Schmidt College of Medicine at Florida Atlantic University in Boca Raton, Florida. I was invited by Professor Kimchi to give an invited lecture at the International Academy of Cardiology meeting here in Boston in late July of 2018, and my topic is the need for individual clinical judgments in prescribing aspirin in the primary prevention of cardiovascular disease. Specifically, in patients who've already survived a prior heart attack, a stroke, or peripheral vascular disease, or who are undergoing an acute MI, aspirin has statistically significant and clinically important benefits, and the risks of aspirin, which are mainly extracranial bleeding, are very low in relation to the magnitude of the benefits. In primary prevention, we have a conundrum because although the relative benefits are similar, the absolute risk of the patient is far lower, so the absolute benefit to primary prevention patient is lower, and yet the absolute risks are higher. Further complicating the situation is that of the 100,000 or so patients in the large randomized trials and the comprehensive worldwide meta-analyses from Oxford, only 4.8% is the 10-year risk of a first event. And of those who have a greater than 10% risk, which is the usual cutoff above which people feel that the benefit will outweigh the risk, only 9% of the patients were in that category. So at present, the data are insufficient on making any general guidelines for aspirin in primary prevention. We don't want to throw the baby out with the bathwater, however, because in the United States, at least, over 40% of adults over 40 have metabolic syndrome, a constellation of obesity leading to dyslipidemia, hypertension, and insulin resistance as a precursor of diabetes. Their risk of a first event is about as high as someone who've already suffered a prior event. So in these high-risk patients, the benefits of aspirin are likely to outweigh the risks. In addition, it should be noted that the benefits of aspirin are at least additive to statins, and it should be on an individual basis considered by a primary health care provider only after he or she feels that the residual risk of a patient is sufficiently high to warrant the side effects of aspirin. Fortunately, in the next few years, we'll have 3 or 4 randomized trials in patients in primary prevention published, and we'll have a totality of evidence that will allow us to make more rational individual clinical decisions for patients and policy decisions for the health of the general public.
Perfect. Now, can I ask you a quick question? I know you're probably in a hurry, but
I'm not in a hurry.
Okay, I thought maybe you were. Okay, so let's talk about what benefit do you see yourself in attending the Congress, like the Cardiology Congress here, both for yourself and maybe someone new in the field, like the rubbing the shoulders for ideas? What benefits do you see?
Well, I've been attending these International Academy meetings for many years. And over the years, of course, the initial appeal was to be rubbing elbows with fellow young and middle-aged investigators who are at the cutting edge of research. However, at this time in my career as a mentor to the young people, this Congress provides an outstanding venue to help place the young residents in cardiology fellowships and the young cardiology fellows into academic positions that will further the goals of the Congress and will help reduce the risks of cardiovascular disease, which will remain the leading killer in the US and developed countries and is rapidly becoming so worldwide.
Very much. That's perfect.